Ren and I will be presenting on brachial plexus birth palsy. Brachial plexus birth palsy, or BPBP, is an injury during birth and results in the paralysis of the upper extremity. The brachial plexus is a complex network of nerve that runs from C4 to T1 and originates between the scalene muscles and extends down to supply motor and sensory innervation to the upper limb. This network is what allows for coordinated movement and sensation during functional activities. In BPBP, the exact cause of injury is not clear, but it's often linked to excessive traction or compression during delivery. The most commonly affected nerve roots are C5 and C6, which impacts the shoulder muscles. If injury extends to the C7, the triceps can also be affected. In more severe cases, all nerve roots from C5 to T1 can be damaged, and this is referred to as total plexus palsy and results in complete non-functional arm. There's two types of brachial plexus birth palsy. The first is Urbdenchi syndrome, which is a lesion to the upper trunk of the brachial plexus that comprises of the C5 and C6. The second one is Clump's syndrome, which results from the compression and contraction of lower trunk, consisting of the C8 to T1. Babies that have this injury experience complications such as weakness and joint impairments. Although full recovery is possible, 30% of the children that have it have incomplete recovery. There is no evidence to support that there is cognitive delays in kids with brachial plexus birth palsy, as it is a neuromuscular disorder and it only affects the peripheral nerves. Some physical features we might see in children with brachial plexus birth palsy is the right arm is in adduction, the shoulder is internally rotated, the elbow is extended, and you also see the wrist being flexed. This can result in a decrease in shoulder strength as well as range of motion. It also results in lack of upper extremity movement and the kids preferring one extremity over the other. And then you also see a loss of motor reflex. Because symptoms can differ from children to children, several studies have tried to predict the neurological recovery milestones. Partial return of elbow flexion by 2 months indicates a positive sign, indicating a full neurological recovery. But if it doesn't return by 3 months, it's linked to incomplete recovery with a reduced shoulder strength as well as limited range of motion. With brachial plexus birth palsy, one of the main concern is how it affects the shoulder. Oftentimes, we will see limited range of motion and muscle weakness in the affected arm, and over time, this can impact how the glenohumeral joint develops. Some of the more common impairments we might see includes internal and external rotation contractures, and in severe cases, structural issues like the glenohumeral deformities. We may also see joint instabilities like subluxation or even full dislocation of the shoulders. All of these factors contribute to functional loss in the extremity that can significantly impact the child's ability to engage in daily activities. There is a few categories of factors that can be associated with brachial plexus birth palsy, including maternal, obstetric, and neonatal factors. One of the most common complication is shoulder dystocia, with it having a 100-time increased risk of developing brachial plexus birth injury. Other contributing factors includes using a instrument-assisted vaginal delivery, such as using forceps or vacuums, which can also increase the risk of injury. We might also see associated injuries like clavicle or fractures of the humerus, breech presentation, or signs of fetal distress that can lead to hypotonia after birth, all of which play a role in development of the brachial plexus birth palsy. Brachial plexus birth palsy affects about 1 to 3 per 1,000 live births. While some cases do resolve on its own, about 30% of the affected children go on to experiencing permanent paralysis. This can lead to several secondary complications, including persistent muscle weakness, joint contractures, deformity or dislocation, and even altered growth of the affected limb. Although early research suggests that over 90% of infants recover spontaneously, more recent research has contradicted that. About 36% of infants may experience long-term functional deficits, highlighting the importance of early intervention and close monitoring.
Here are some key symptoms that may interfere with occupational performance. In cases, we may observe neuropraxia, nerve traction, or root avulsion depending on the type of brachial plexus injury. So this can disrupt nerve signaling, leading to weakness or specific paralysis in the arm. This results in asymmetrical arm movements and asymmetrical motor reflex. These are both critical for early motor skills, and birth injuries can even cause scapular winging, so this is due to any bony damage. And more specifically, let's talk about the symptoms of the two common types of brachial plexus birth injuries. So in Klemke's palsy, which is rare, it affects the muscles that innervate the lower trunk of the brachial plexus and causes paralysis in distal wrist flexors and intrinsic hand muscles. And this often presents as a shape known as that looks like a claw hand. The second is Erb's palsy, and this is the more common type. So this affects the upper trunk of the brachial plexus. So key features include an adducted and internally rotated shoulder, extended elbow, and a pronated forearm with maintained grasp, and this kind of looks like, or is referred to as the waiter's tip position. And then at the bottom of the slide, the figure illustrates the features of Erb's palsy, so this provides a clear example of the postural representation of it. So brachial plexus birth palsy affects critical development occupations across various early childhood stages. So from birth to 6 months, sensory motor play is impacted. And this is particular in activities like reaching or grasping for toys with affected hand. So babies might struggle with symmetrical weight bearing during tummy time, and this is essential for their motor development. And then at 6 to 12 months, functional and exploratory play can be a challenge. So tasks like passing toys between hands, crossing the midline, crawling symmetrically, or picking up small objects that require bimanual coordination, it's going to be limited. And then between 12 and 24 months, relationship and functional play, so this is can be affected due to decreased schema and diminished in-hand manipulation, which in effect can affect games like stacking blocks or using shape sorters. Even everyday tasks such as self-feeding may need adaptations. And then finally, from 24 to 36 months, constructive play is often impacted, so bimanual activities like building with blocks again, drawing, solving puzzles. This requires stable use of both hands, and it's going to be impacted as well. So medical management varies based on severity and their diagnosis. Early intervention within the first month of age can greatly increase the chance of full recovery. However, 10 to 30% of cases may experience lifelong neurological defects, so this is going to be experienced throughout their life. Surgical interventions are considered when there's no improvement by age 3 months, particularly with unimproved bicep strength or if there's any presence of glenohumeral dysplasia. Now, there are surgical options like nerve reconstruction, nerve grafts, and extra plexus nerve transfers, and these aim to restore nerve function and prevent any further complications. In pharmacology, Neuropathic pain is managed by medications that are used to treat epilepsy or seizures, such as gabapentin or pregabalin, also known as Lyrica. Side effects of these medications would include drowsiness, vertigo, or ataxia, and this can hinder a client's participation in occupational therapy. So, for example, drowsiness may limit attention during therapy, while balance impairments from vertigo or ataxia could affect safety during functional mobility tasks. Another pharmacological intervention that could be used when contractures resist therapy would be Botox injections, and this can be used to improve range of motion and functional engagement. So, by understanding these interventions and their effects, we can better support our clients in achieving optimal outcomes and understanding what effects they may have during our interventions. Occupational therapy plays a critical role in supporting kiddos with brachial plexus birth palsies. Our primary focus as OTs for infants and toddlers is to encourage the achievement of typical development milestones through various interventions. And these interventions will include education for the family and the caregivers. We also want to promote participation in age-related activities so we can assess and enhance functional abilities. This often involves muscular strengthening and addressing contractures through techniques like splinting, casting, passive range of motion exercises, and this is to maintain flexibility and prevent any deformities. OT also works in collaboration with other therapies in a multidisciplinary approach. So this includes orthopedic and physical therapy, and they focus on passive range of motion, contracture prevention, and reducing any compensatory movements in the future. Together, these therapies will aim to optimize functional outcomes and improve the quality of life of our clients. Now, as a child gets older, and even in adulthood, evidence shows that even with persistent functional deficits, individuals can achieve positive long-term outcomes. And these include independence in ADLs and an overall really good quality of life. So the prognosis for individuals with BPBP varies, and it depends on the severity and the extent of recovery. And at a point, it can significantly impact functional daily living. So according to Dorich et al. 2024, challenges will often come from limitations in arm use and hand use. So tasks like dressing and writing become a lot more difficult. This can reduce in participation in activities, affecting their life roles, and really take a toll on their emotional well-being. And one participant in the study stated, "I can't swim or do things like yoga," which I had always wanted to do. And this was a recurring theme in the statements throughout the article. Others would describe living with effects of the condition as mentally draining, emotionally suffering, and painful. And additionally, many of the participants reported difficulty maintaining employment or avoid certain activities, and it further affects their quality of life. So these findings emphasize the need for early interventions and long-term support to help them overcome challenges and achieve best possible outcomes in OT.
For our case study, we have Sella, who is a 12-month-old baby. She was born via difficult vaginal delivery that resulted in shoulder dystocia. Due to the traction in her upper brachial plexus, she was diagnosed with Erb's palsy on the right side. She lives with her 8-year-old sister and parents in a 2-story house in Irvine, California. She spends most of her time with her mom, who is on maternity leave, while her dad works full-time at home and her sister is at school. Sella presents with limited active range of motion in her right shoulder and elbow, resulting in her using her left arm during playtime and feeding. Her mom reports that she notices that Sella has a hard time tolerating tummy time and demonstrates delayed gross motor for an infant her age. She is unable to roll from prone to supine and has a hard time grabbing items with both hands. She enjoys toys with bright lights and music while responding well to her sister's voice. Her strength includes social engagement with her family, visual tracking skills, and emerging vocalization. She calms at the sight of her mom and dad's voices and faces. She has a hard time using her right hand, showing a decreased tolerance for being in prone position. Her parents are worried about her functional development and feels overwhelmed with caring for both children. She is receiving occupational therapy, early intervention in an outpatient clinic to work on improving functional mobility in her right upper extremity. Her occupational therapist is working closely with her parents to work on feeding, grasping items, and floor play. For the first occupation, we focused on play, specifically the ability to reach for toys across midline. This action requires several client factors, including adequate muscle power and tone to support movement, as well as sensory and proprioceptive functions to help the child understand where their body is in space. In terms of performance skills, we're looking at whether she is able to reach effectively, coordinate both sides of her body, stabilizing her trunk, and position herself in a way that can support this activity. And for the second occupation, we did feeding, specifically the ability to hold a bottle during feeding time. This is an important early self-care skills that supports independence and regulation. Several client factors includes global mental functions like arousal and attention to help her stay alert and focused during feeding. Sensory function, especially tactile input, are necessary for recognizing and adjusting grip. And then lastly, muscle power and tone are necessary for supporting and sustaining the movement. For performance skills, we are looking at whether she can grip the bottle, manipulate the bottle as needed to maintain position, and endure through feeding without fatigue or disengagement.
Brachial plexus birth palsy doesn't just impact physical function, it also has profound psychosocial implications for both the client and their family. And in Stella's case, her Erb's palsy limits the use of her right arm, affecting her ability to play and engage in age-appropriate activities, and this may lead to frustration or decreased confidence as she grows older. And this aligns with findings from Dorich et al. 2024, where adults note describing their experiences growing up with BPBP as mentally draining and emotionally taxing. For Stella's family, the psychosocial challenges are evident. So her parents are overwhelmed, they're caring for her and her condition, they're also caring for their other child, and they're also worried for Stella's functional development. And Dorich et al. Also notes that families often face a burden of caregiving and limited family activities. So Stella's family may experience this as they navigate therapy appointments and any changes into their daily routines. So by also addressing these psychosocial concerns in occupational therapy, we can also support both Stella's development and her family's well-being. Meanwhile, navigating their challenges and celebrating milestones she achieves. Here's the list of our references that we used for our presentation. And thank you so much for listening.